Hello, my name is Elizabeth Denver and I run a nurse-led hypertension clinic in the Department of Diabetes in Whittington Hospital in London, in England. I'm going to talk to you today about treating hypertension in a diabetic patient. But first I'm going to go through measuring blood pressure, because accurate recording of blood pressure is very important when treating somebody's hypertension, as otherwise if we don't do it accurately the treatment becomes very difficult. First of all, it's important that the patient is sitting comfortably and is relaxed with their back supported. The arms should be held straight, preferably as close to heart level as possible. And the right size cuff should be used. If the cuff is too large, you will underread the blood pressure, and if the cuff is too small, you will overread the blood pressure. Just get the patient to relax their elbow and make sure their forearm is straight. If the forearm is held upwards, you will underread the blood pressure, and if the forearm is hanging down, you will overread the blood pressure. It's also good, if possible, to have a checked and validated blood pressure machine, and certainly it needs to be calibrated probably once a year. When you're taking the patient's blood pressure, make sure that you don't talk and they don't talk. Take the first reading and then wait 2 minutes and take a second reading. Okay, so that's accurate blood pressure measurement dealt with. I'm now going to talk about targets for blood pressure in patients who have diabetes, and these targets are based on UK guidelines. Our target for somebody who's got diabetes is a blood pressure of less than 130/80. The reason for this is that patients who have diabetes are already at increased risk of cardiovascular disease. And if they have high blood pressure as well, this increases their risk. The risks involved are heart disease, stroke and renal disease, as well as macrovascular effects on the retina. We know that many factors can affect blood pressure, and diet in particular can have a very profound effect on blood pressure. A high salt intake, a high fat intake, a low intake of fruit and vegetables, patients who don't do much exercise, patients who are overweight, patients who have too high an alcohol intake can all increase their risk of hypertension. Therefore, when we're looking at treating hypertension, one of the first areas is looking at lifestyle. Talking to patients about their salt intake is very important, and about their fruit and veg intake, but you also need to be familiar with the kind of diet they normally have. In the United Kingdom, we have a population that is very diverse, and so it's useful for the healthcare professional to be familiar with the diet of people from many areas of the world. Exercise is another area where we know that blood pressure can be lowered if people can increase their exercise, but many people do not do any exercise at all. So when you're talking to your patients about exercise, you need to start from where they're at. If you have somebody who is already going to the gym 3 times a week, then maybe you're looking at getting them to do other exercise in between that. But if you're starting with someone who doesn't do any exercise at all and virtually never goes out of their house, then you need to start with something very simple, such as maybe walking around their house a little bit or into the garden. We also try to encourage our patients to stop smoking, because although blood pressure is not actually affected by smoking, coronary heart disease is, and diabetes is also affected by people smoking. So we try to encourage smoking cessation. We try to encourage our patients to eat more fruit and vegetables. Even the diabetic patient can have their 5 fruit and veg a day, so long as they space them out throughout the day and don't have all their fruit at one meal, as that will adversely affect their blood sugar levels. Alcohol intake again can be an issue, and patients may be drinking more than the recommended amount per week. In terms of medication, our first line treatment for people who have high blood pressure and diabetes is an ACE inhibitor. The second line would be either a thiazide or thiazide type diuretic or a calcium channel blocker. If that does not bring sufficient blood pressure control, we would then add in the third element, which would be the thiazide or the calcium channel blocker that you hadn't already prescribed. We have to remember when prescribing for patients who've got diabetes that these patients may already be taking 2 or 3 medications for their diabetic control. They're probably also on a statin for their cholesterol levels, and they may well be on a low dose aspirin as well. So when we're adding in blood pressure tablets, we may be asking the patient to take 10 to 15 tablets in the morning and maybe 5 or 6 in an evening. So trying to use once daily preparations where possible is always helpful, and if there are combination tablets, that can also help. We also need to be aware of side effects of these medications, and also the fact that people who have high blood pressure or hypertension don't actually feel ill on the whole. If their diabetes control is poor, they can usually tell because they feel dizzy or they feel unwell. But when your blood pressure is high, most of the time you don't realise it until something happens, such as a stroke or a heart attack. So working with your patients is very, very important. Discussing with them why they're having the blood pressure medication, explaining what blood pressure is, explaining what the dangers of high blood pressure is a very important part of the whole process. We also work with self-management in this hospital, and we try very hard to encourage our patients to understand the disease that they have and to understand the factors that affect it and the kind of treatment that will help them. We find that this improves their concordance with their medication, and also often is the motivator for them to make the lifestyle changes that are required. I said that we have a target of 130/80 for our patients who have diabetes. We don't always achieve this in every patient, but we try very hard to work with the patient to get as near to that target as possible in order to prolong their life and make it as complication-free as possible.